Park, an attending physician at the Seattle Children's Hospital and professor in pediatrics at the University of Washington School of Medicine in Seattle, Washington, who will present a finding of a phase 3 trial exploring tandem versus single autologous stem cell transplant as consolidated therapy for children with high-risk neuroblastoma. Dr. Park.
Good morning. I'm honored to be able to present the results of our randomized clinical trial studying tandem myeloablative autologous stem cell transplant as consolidation therapy for high-risk neuroblastoma. I present this on behalf of the Children's Oncology group and our study committee of AMBL 0532. Most of you are probably not very familiar with neuroblastoma. It is a disease of early childhood and the most common extracranial tumor of childhood. It's a tumor that arises in neural crest cell origin in tissues of the sympathetic nervous system. It occurs in very young children with a median age of less than 2 years of age. Clinical and biological characteristics are used to determine prognosis and identify children who are at high risk for tumor recurrence and ultimately death from this disease. And utilizing current therapies, less than 50% of children with high-risk neuroblastoma will survive following a very multi-agent and aggressive therapy. Prior clinical trials had demonstrated that dose intensification of therapy improved outcome, and this included the use of a single autologous hematopoietic stem cell transplant. This led us to hypothesize that further dose intensification of consolidation could improve outcome for these children. We performed pilot studies utilizing tandem transplant and demonstrated tolerability and with potential suggestive efficacy. Our prior trials also demonstrated our ability to collect peripheral blood stem cells early on in treatment, which was necessary to proceed with a tandem transplant modality. Our trial schema is explained here. 665 children were enrolled on the treatment and received an induction regimen of 6 cycles of chemotherapy. Peripheral blood stem cells were harvested after the initial 2 cycles of chemotherapy, and patients underwent resection of their primary tumor after 5 cycles of chemotherapy. Patients then underwent evaluation, and those who met criteria for randomization, which included adequate stem cell collection, adequate organ function, and no evidence of disease progression, went on to randomization. Patients were randomized between our standard arm of carboplatin, etoposide, and melphalan versus our experimental arm of cyclophosphamide thiotepa, followed 6 weeks later by a dose modification of the carboplatin, etoposide, and melphalan. All patients went on to receive radiation therapy of their primary site. Patients enrolled in this trial were then eligible to go on to enroll on ANBL 0032, a clinical trial being performed in the Children's Oncology group investigating post-consolidation immunotherapy. Approximately 70% of those randomized went on to actually receive immunotherapy. This is important as prior clinical trials have identified that immunotherapy of anti-GD2 antibody in combination with isotretinoin improves outcome for children with high-risk neuroblastoma. Our results are represented here. Those children who were randomized and received a tandem transplant had a statistically significant improved event-free survival with a 3-year event-free survival of 61% compared to those children receiving single transplant with a 3-year event-free survival of 48%. Our median survival of this cohort is 4.6 years. There was not a statistically significant difference in overall survival, but this is clearly seen on our prior studies. Our study was designed and powered to see a change in event-free survival, and overall survival has likely not been followed long enough to show a difference. In those children who went on to receive immunotherapy, we still see a statistically significant benefit for those children who received tandem transplant as compared to single transplant, with a 3-year event-free survival from the time of receiving immunotherapy of nearly 74% for these children. In this cohort of children, there is a statistically significant improvement in overall survival for those children who receive tandem transplant. In conclusion, tandem transplant consolidation improves the outcome for children with high-risk neuroblastoma. I did not show the data, but toxicity and regimen-related mortality were not increased by using tandem transplant, and the benefit of tandem transplant remains following anti-GD2-directed immunotherapy. I thank you for your attention.
Thank you very much, Dr. Park. I think this, again, shows the power of all of us working together to place patients on clinical trials, and with this information, we can try to make true improvements in patients' outcomes of all types. And certainly the pediatric groups have really been at the forefront of doing this, and we appreciate that.